Hello friends, hope you are all okay. You are all enjoying your life. You are all enjoying watching my videos and taking useful information and also enjoying practicing ultrasonography. Today I am going to discuss about the metastatic liver disease. It is highly sensitive topic, highly important topic. Metastatic disease is a very common, even 18 to 20% more common than hepatocellular carcinoma. Metastatic disease and the early detection of METs can alter the patient prognosis and sometimes even management. On the grayscale ultrasonography, it shows multiple presentation. Sometimes it presents as a focal nodular mass on the liver, but most often it presents as a multiple focal masses within the liver parenchyma. Basically, it has four types: hypoechoic mets, hyperechoic mets, calcified mets, and cystic mets. And these all mets shows their primary origin of the cancer, how it will appear on the ultrasound images, how we will appreciate, how we will distinguish all that. Keep watching these images, and I'm sure you will enjoy learning. Look at this image. It's the image of liver with multiple small echogenic foci. These are echogenic metastases and more common in renal cell carcinoma. Quite often clinicians confuse with hepatic calcification and mark it as benign calcification, which are actually healed granulomas. But the one distinguishing feature between malignant echogenic mets and benign calcification is aqueous-stick shadowing. Calcification will cause significant aqueous-stick shadowing, while echogenic mets does not produce any sort of a shadowing. So mention on the report the size, site of the echogenic lesion. If these are multiples in number, mention the size of the largest lesion, and especially mention that which site is being occupied. If it is in diffuse form, so mention that it is interrupted or lesions are interrupting the entire liver parenchyma. This image is from the colonic cancer patients. You can see clumps of calcification within the right lobe. Actually, these echogenic foci are malignant metastatic deposits, and colonic cancer mets usually shows such presentation. This could be single or they may appear as multiple. Measure the size and give the location within the liver. This is the another slide. Here on this slide you can appreciate that small tumor within the right lobe of the liver is visible. You can also appreciate the vascularity of the liver. This patient is suffering from adenocarcinoma. Within the tumor you can appreciate microcalcification. These are called as punctate microcalcifications. Sometimes it appears in clumps form, or sometimes it may appears in diffuse form, but in clinical practice you will always appreciate these microcalcifications in clumps form. This slide is just for the revision to make understanding more clear about the echogenic metastasis. Echogenic metastases are usually seen in renal cell carcinoma, in carcinoid tumors, in neuroendocrine tumors, especially in choriocarcinoma, and in some of the cases islet cells carcinoma. You have already seen the images, and I'm sure you will be able to appreciate this echogenic metastasis on the ultrasonography. Echogenic metastasis, those tumor which are highly vascular, they causes echogenic metastasis. It include renal cell carcinoma, so mets from the renal carcinoma would be highly echogenic. Neuroendocrine tumor, carcinoid, and choriocarcinoma. These primary tumor can causes echogenic metastasis, especially in the liver. One important point worth mentioning here, that it mimics as an hemangioma. You can't really appreciate between hemangioma and echogenic mets because it looks both similar on the ultrasound imaging. One is benign tumor, like hemangioma is benign, and another one is malignant echogenic mets. So therefore further workup is very important to differentiate between these both entities. In this slide, right lobe of the liver shows a well-defined hypoechoic lesion. This right lobe is occupied by a well-defined hypoechoic lesion. This lesion shows marginal irregularity. Its margins are irregular, therefore you can call this tumor as a lobulated mass or lobulated tumor. Mention the size and site of the tumor, mention its echogenicity, and also discuss its marginal irregularity. Put the Doppler signals on the tumor and look for vascularity as well. You should not confuse with focal fatty sparing area, as the entire liver looks echogenic and fatty, so you may confuse with the fatty sparing area, because this appearance of the lesion shows like it's a focal fatty sparing area. So this is not the focal fatty sparing area, this is hypoechoic metastasis. On this slide, you can appreciate multiple confluent masses. These are joined together in such a way that it looks like a single tumor, which is actually not. These are confluent hypoechoic masses. These are hypoechoic metastatic deposits, mainly occupying the left lobe, and this would be segment 3 of the liver. So far the right lobe is concerned, it's totally clear and you cannot appreciate any of the lesion within the right lobe. Margins of the liver are also smooth. Again, this lesion mimic as focal fatty sparing area, but make sure you are not confusing the lesion and not misdiagnosing the hypoechoic metastatic deposits. This slide is quite clear and you can appreciate multiple well-defined hypoechoic masses, mainly in the left lobe segment 3, superior to the gallbladder proximity, and right lobe is also involved. Remaining parenchyma of the liver is normal, margins of the liver are smooth and regular, portal vein is clearly visible. You can appreciate CBD as well. So these are focal hypoechoic metastatic deposits involving right and left lobe subsequently. So these masses are having smooth margins, round margin, and it does not distort the liver parenchyma, and vasculature of the liver appears also normal. So these are focal hypoechoic masses involving the right and left lobe of the liver. On this image you can appreciate a highly rare presentation of hypoechoic metastatic deposits. It looks as these lesions are sliding downward from the left lobe of the liver to the right lobe. Somewhat you can call it as an infiltrative form. Infiltrative diffuse tumor look like this. Almost entire left lobe is occupied, gallbladder is compressed, and tumor is marching towards the right lobe. This is a rare geographic pattern of hypoechoic metastatic deposit. You have to just mention the size, mention the location and area, and also mention about if the vascularity is compressed or it is distorted, or what about the liver margin, is it penetrating, or the liver margins are irregular, or this lesion is extruding out from the liver margin. So you have to mention all that. Same patient CT image shows a well-defined liver. You can appreciate again an infiltrative lesion, diffuse infiltrative lesion, which is almost occupying the entire left lobe. However, this this lesion is confined to the liver margin. It is not protruding out from the liver. On the CT scan you can appreciate well-defined margins are smooth, regular. As far as CBD portal vein is concerned, clearly visible on there. But one thing is worth noting here, like you cannot appreciate the vascularity where the infiltrative lesion is. So there must be some primary lesion somewhere. You have to search carefully on the CT scan that where the primary lesion is, because this lesion is a diffuse tumor and involving the left lobe, and this is a classical example of a diffuse infiltrative hypoechoic metastasis of the liver. It is just to refresh the knowledge, hypoechoic metastasis can be seen in gastric tumors. Many of the gastric tumors appears hypoechoic, their mets appears hypoechoic within the liver. Pancreatic tumors, esophageal tumors, and liver is the primary site for the lymphomas, especially non-Hodgkin types. Non-Hodgkin lymphoma appears hypoechoic on the ultrasound images in the liver. Hypoechoic metastasis. Hypoechoic mets are usually avascular. If you put Doppler signal on the tumor, so you will either appreciate no vascularity or maybe very rare or sluggish vascularity. Hypoechoic metastases are from the gastric tumor, from the pancreatic tumor, and from the esophageal cancer. So these three tumors can cause hypoechoic mets. Those mets which are not treated, especially mets from the lungs and mets from the breast, if it remain untreated, it will also appear as an hypoechoic. Non-Hodgkin lymphoma also appear as hypoechoic. In bronchogenic carcinoma, metastatic deposits will appear as a target lesion within the liver. You can call it target lesion, bull-eye sign, or halo sign, whatever easy for you. These all three characteristics follow the same meaning. This slide shows a target lesion centrally echogenic and having surrounding hypoechoic halo. You can appreciate this lesion in the left lobe, especially around the subcapsular margin. Portal vein is visible and it's not occupied, it's not compressed. CBD is also visible, CBD is also not compressed, and the other part of the liver is clear. So usually this sort of a lesion can be seen in bronchogenic carcinoma. This is another example of bronchogenic metastatic deposit. It's comparatively large lesion, centrally hypoechoic and having hypoechoic surrounding, which is called as hypoechoic halo. You can call it as halo sign or bull-eye sign, or you can call it as target lesion, whatever is convenient to you. Most commonly in the reporting, target lesion word is used, so it is better to use the word while writing the report. Portal vein is clearly visible on its left side in the slide. Tumor margins are smooth and clear. Centrally hypoechoic area is clearly visible and there is no calcification within the tumor. Another specific presentation which is called as a bull-eye sign or called as a target lesion. This is a specific and special entity on the ultrasonic imaging. If you come across with a tumor which having a surrounding halo, it will represent as a bull-eye sign, or it will called as a halo sign or target lesion. These both are very common in bronchogenic carcinoma. So it has a specific entity. So whenever you come across these two signs, either you can call it a target sign or you can call it as a bull-eye sign. So these both would be very common in bronchogenic carcinoma. This slide is the clear example of calcified metastatic. While talking about the calcified mets, calcium may appear as large echogenic and shadowing foci, or more often shows innumerable tiny punctate echogenic foci without clear shadowing. Here on this slide you can see this is a dense calcific foci. It's causing shadowing, but this shadow is not clear. It's occupying right lobe of the liver. No other area is involved. All other part of the liver is clear and you can easily appreciate a clear liver. This is another example of calcified mets. You can appreciate the right lobe of the liver, and here you can see at least 4 dense calcific foci with dirty shadowing. So these are calcified mets. There are multiple wide range of primary cancers which causes calcific metastasis, including adenocarcinoma and leiomyosarcoma, but this will appear in this way. Like I have shown you these two images, this is also a particular image, but you have to be very careful while writing calcific mets, because you have to mention it that this is metastatic disease, and some of the time it may confuse with benign calcification of the liver, which are usually healed granulomas. So most of the time healed granulomas may also appear as calcific foci, but here you have to be very careful while writing either calcific foci as a metastatic deposits or calcific foci as a granulation tissues. For the revision purpose, have a look for the calcified metastasis primary tumors. It include mucinous adenocarcinoma primary tumors, endocrine pancreatic tumors, leiomyosarcomas, adenocarcinoma of stomach, neuroblastoma, osteogenic sarcoma, chondrosarcoma, ovarian cyst adenocarcinoma, and teratocarcinoma. This is a wide differential, wide variety and wide range of primary tumors which are causing calcified metastasis. Calcified metastasis. Calcified mets are from endocrine tumors, especially pancreatic endocrine tumor, leiomyosarcoma, neuroblastoma, osteogenic sarcoma, chondrosarcoma, ovarian cyst adenocarcinoma, and teratosarcoma. These are all appear or represent as an echogenic foci within the liver, or sometime you will come across a tumor which will be having multiple calcific foci within it. The one important thing is to differentiate here. Sometimes there are small calcific foci within the liver parenchyma which are due to calcified or healed granulomas. So you must be very careful while differentiating these both, whether these are healed granulomas or these are calcific mets. So again, I would say here that further workup must be advised to differentiate between these benign and malignant entities. Have a look, and on this image you will be able to appreciate a well-defined complex cystic lesion. You can describe it as a complex cyst with predominant cystic areas, or you can call it as multiseptatic cystic lesion, or you can also describe it as a cystic lesion with solid soft tissue components. It's actually a liposarcoma involving thigh region. Lipoma is very common and involving almost all parts and areas of the body, mainly where adipose tissues are at large. But care must be taken if you see any degenerative changes or hypervascularity within the irregular fatty tumor. You must suspect malignancy. Liposarcoma causes liver mets, which are usually cystic, and you have already appreciated this cystic lesion within the liver, which is actually cystic metastatic deposit. Here is another slide of cystic metastasis for you. This is small bowel cancer, and you can see its cystic mets within the liver. Here this cyst looks simple cyst, no marginal irregularity and no thick wall is seen, no intramural nodule is visible. But one change is you will be able to appreciate, which is interface between the liver and cystic mets. This is actually a reactive response to the lesion and can be picked if you carefully scan the patient. Otherwise, this case can be easily missed and labeled as a simple cyst, and you can easily miss cystic metastasis. So care must be taken while there is simple cyst within the liver. Always ask, always take history, always look for the notes, and always mention if you did find any suspicion within the simple cyst or around the cyst. Mention on your report, and always advise further radiological imaging. Carcinoid and endocrine tumors cysts will also appear as complex cystic lesions. On this slide you can appreciate a cyst, but if you look around the cyst you can appreciate a response of interface which is slightly hyperechoic. Cyst is itself simple, there is no intramural content, wall is almost regular. But if you look for the response of interface, so you can appreciate that there is thick response and that area becomes hyperechoic. Always be careful for cystic lesion within the liver. take history of previous illness, recent surgery, and other imaging reports if there is any. Just for the revision purpose, cystic metastasis can be seen with cystadenocarcinoma of ovary and pancreas, and mucinous carcinoma of the colon. These three are the areas which usually give rise to cystic metastasis in the liver, and you have to appreciate it from the simple cysts. Cystic metastasis. Cystic metastases are those mets which appear cystic on the liver. And the one important thing is you have to distinguish it from the simple cyst of the liver. The distinguishing feature from the simple cyst is if a cyst containing intramural nodule, or if a cyst containing a thick wall, or if a cyst containing fluid level or internal septation, this could be suspected as a cystic metastasis. Cystic metastases are usually from the cystadenocarcinoma of the pancreas and ovaries, mucinous carcinoma of the colon, neuroendocrine tumors and carcinoid tumors, and large metastasis of the colon because of necrosis and intratumoral degenerative changes. These are all appear as a cystic metastasis within the liver. Diffuse infiltrative metastatic disease can be seen in breast carcinoma, in lungs carcinoma, and malignant melanoma. Have a look and you will find an infiltrative pattern of hypoechoic lesion. This is actually diffuse infiltrative form of the metastasis, especially hypoechoic metastasis, and it has its own characteristic. It's usually seen as it's occupying the left lobe, entire left lobe is involved, right lobe is okay, and margin you can appreciate it's all well. Portal vein is clearly visible, so this is a particularly diffuse infiltrative pattern. This type of a metastatic pattern is really difficult to appreciate and distinguish. Most often you will miss this pattern because this is also an diffuse infiltrative pattern, and almost all of the liver is involved, entire liver is obscured. However, if you look for the internal vasculature, you won't be able to appreciate internal vasculature. And the second thing is, so far the compressions of the vasculatures are concerned, you cannot easily document that. So this is another example of diffuse infiltrative pattern. So this was all about the metastatic liver disease. I'm sure you will be able to understand how hypoechoic metastasis will look on the ultrasound imaging, how you will differentiate hyperechoic, echogenic, and calcific metastasis, and specific entity of the cystic metastasis as well. So as it is very complex structure, you cannot really appreciate and confirm it on the basis of the ultrasonography. So therefore ultrasound guided biopsy is widely used to diagnose all these malignant categories. So far the ultrasonic reporting are concerned, you have to be very specific while writing the report. You have to mention the size of the cyst or the size of the tumor. You have to mention the site of the tumor as well. Along with, you should mention the status of the liver, its regularity, its parenchyma. Explain how this tumor look on the ultrasound images. Beside this, when you are concluding your report, you mention that this is the structure, this is the tumor, and you differentiate this, and your differential is whatsoever you want to write on and according to your knowledge. So make sure these are all the information. These are very specific information. If you have that in your back of your mind, you must put it on the black and white, but try to be short as much as possible and short your differential to help your colleagues to further work up on it. So I'm sure this would be a very useful video for you, and you will definitely give me the feedback on this. Lymphoma is a malignant condition which almost involve all of the organs of the body, especially liver. On the liver, you will appreciate lymphoma as a small hypoechoic multiple nodules. There are two categories of the lymphoma: Hodgkin lymphoma and non-Hodgkin lymphoma. Especially this slide which I am going to show you next, that is from the non-Hodgkin lymphoma, which appear as a small hypoechoic nodules within the liver parenchyma. If you look carefully to this slide, you will be able to appreciate multiple well-defined hypoechoic nodules within the liver parenchyma. These nodules have a very smooth margins, small size. Liver parenchyma is otherwise normal. This pattern is usually seen in lymphoma and especially Hodgkin lymphoma, which appears hypoechoic. Lymphoma involves almost all the organs of the body, but the liver presentation will be like this. It will also mimic as metastatic deposits, especially hypoechoic metastatic deposits appears like this. It usually appears multiple. So as you see that this slide shows multiple small focal hypoechoic lesion. So it's always better to do further radiological imaging to confirm the lymphoma, because the lymphoma and metastatic deposits, it has different management. So therefore always advise further workup to confirm the presentation of lymphoma. Here you can see another slide of Hodgkin lymphoma. It is the same slide, but you can see there are two focal lesion, focal small hypoechoic lesion. Sometimes it give rise to appearance of cyst, but if you carefully scan, so you will find out these are not the cysts, these are small hypoechoic focal nodules. So these are the classical examples of Hodgkin lymphoma. So again I will mention here that if you come across such sort of nodules, you always try to advise further radiological workup, because it is important to differentiate between whether these lesions are lymphoma or these lesions are metastatic deposits. While writing the report for malignant hepatic masses, make sure you have taken proper history and supported documents with details of investigations, because history and investigations will help you to diagnose accurately, and it will also help you to narrow your differentials. Take the size and numbers of the lesions, its location, describe the features of the lesions, its echogenicity, degenerative changes within the lesion, and also mention about the calcification if any. Must describe Doppler signals because it helps in aggressive lesions. Comments on the liver parenchyma and intrahepatic vasculatures. At the end, while writing conclusion, if possible, give your diagnosis. If not, give your differentials and mention which next modality would be helpful towards the diagnosis. Yes guys, this was all about the metastatic liver disease, and I'm sure you would definitely benefit from this video. Do not forget to give me your feedback. Do not forget to share this video with others. Give it to the others, give this link to the others for the subscription, and also I would highly appreciate if you give your remarks on this video. So hopefully see you in the next videos for some other topic. Keep watching my videos. Stay safe. Take care of yourself. See you then. Bye bye.